I think compliance reasons scare a lot of people. I think people are very frightened of technology that's not FDA approved. I think people find that that's a barrier, and it shouldn't be. People should be able to access the non-FDA approved technology. You're going to have to do the same validation anyway when you're internally validating it. And the College of American Pathologists gives you really good resources. I mean, they basically tell you, step by step what you need to do in order to produce a validation that's considered acceptable, which is, it's just like any other laboratory test. I think that just knowing that there are options out there that aren't FDA approved, and that the validation, the internal validation that you're going to have to do is going to be exactly the same, whether it's FDA approved or not FDA approved. So really, if you think the technology is good, then it's good enough, right?
Welcome, my digital pathology trailblazers. Today, my guest is Dr. Elizabeth Plocharczyk, and she is a pathologist at Ithaca, New York. She's affiliated with multiple hospitals, and she is a true digital pathology trailblazer. So recently, Digital Pathology Place started working with a new partner, Smart in Media. And when I was in conversations with them, I was just asking, who is using your camera? Just to understand better what you can do with it. And they told me, you need to talk to Dr. Plocharczyk. And so I reached out to Beth and asked about her digital pathology journey. And today I'm honored to have her as a guest on the podcast. And I'm so excited to have you share, Beth, because you have such a non-standard digital pathology journey. Welcome to the podcast.
Thanks so much for having me. I appreciate the invitation.
We are going to start with you, with your background and what your pathology practice looked like before digital pathology was part of it.
So I'm a community hospital pathologist. I practice in Ithaca, New York, like you mentioned. Let's see, I'm anatomic and clinical pathology boarded, also boarded in dermatopathology and clinical informatics. So I do have an interest in technology use in medicine. But for the first approximate decade of my practice, I hadn't used any digital pathology tools. I had a pretty standard practice, mostly surgical specimens, biopsies, excisions, cytology, some autopsies, medical direction of laboratories, pretty standard run-of-the-mill community hospital pathology.
So you have a lot of specialties, and were you using them enough before digital pathology? It's kind of a side question because you're boarded in informatics and you said that 10 years you were not doing any digital pathology.
Right. Mostly my informatics training I was using for things having to do with data flow in medicine and making sure, building interfaces with other practices. I have a pretty active outreach practice because of my dermatopathology practice. So I do service a lot of clients all over the state who are dermatologists. And there are lots of heterogeneous medical record systems that we had to get our medical record system to be able to talk to. And so mostly my informatics up to that point was having to do with interoperability.
So you kind of, with this background, you were set up for success because digital pathology also is just part of, a different ecosystem that goes into it. But when did you decide to go digital? When was the point where you said, okay, it's time to go digital? And was it just for certain areas, or how did you do it? And how did you know that digital was the way?
Right. So after about 10 years of practice, I found myself in a one-person practice. Normally, my practice was a two-person practice, and then I found myself working alone. And I found, having to do all of the work with one person, it was very challenging to be able to be in multiple places at once. And even just simple things like scheduling a dentist appointment or, taking some time to do some gardening at home. It was very challenging to be able to have the time and ability to be able to do those things. And so I decided actually during the pandemic, it was in 2020, that it was time to go digital. And I remember the moment that I decided it was time. I was doing a proficiency test on the College of American Pathologists website, and it was a proficiency test in flow cytometry. And I remember looking at the images of the peripheral smear or the aspirate smear, and it was the quality of the images was just excellent. The usability was easy. I was able to navigate the image and zoom in and zoom out without a lot of fuss. And I just remember this being a big change from what I remember digital imaging being when I was in residency. And so I thought, this is a tool that can help me in my practice. And by that point, I was getting socialized to things like remote work because of pandemic, being able to do meetings online, having other, people that didn't have to be in the hospital could not be in the hospital with the pandemic and remote work. And so I think just a confluence of factors fell together. Also, at the same time, because of the pandemic, we had been doing a lot of COVID testing. And because COVID testing wasn't available, we had to develop it ourselves. And so we had to use the laboratory developed testway pathway in New York State to be able to do this sort of testing. And that put in my mind, well, if we're using laboratory developed testing for COVID, why not use it for digital pathology? So all of those factors just came together, and I decided it was time. And that I needed to do it to be able to maintain my practice as a one-person practice, or even as a two-person practice, because times have changed so much.
Yeah, two-person practice is not a huge practice either.
No.
Okay, so you decide to go digital. Can you describe what was impossible before you went digital when you were just one person? What would you run into? How many
Right.
places did you have to drive to? How long was the
Right.
drive? And
Yeah.
when did you realize, hey, it cannot continue like that?
Right. So I would say that there were certain aspects of my practice that very much geographically located me within the hospital. And one of those was frozen sections. If you have a frozen section and it's 6 o'clock and you want to go home and eat dinner, you can't really do that if you're waiting for that frozen section unless you have some sort of technology to be able to extend your reach. The second application that really tied me to the hospital was on-site adequacy assessment for cytology specimens. We do a lot of rows in our hospital, rapid on-site examination and evaluation to triage cytology specimens for FNAs that are happening in radiology or in the OR, for EBISs, for example. So I would say that there were several of those cases per day. And I also needed to be in two different hospitals. And so sometimes I would find myself
How far
driving.
were they from each
Yeah, we live
other?
in a rural area, and I'd be driving to the other hospital, and then I'd get a call saying, "We have a frozen section," and so it would be problematic. I needed to be able to be in multiple places at once. I needed to be able to go home sometimes. So those were the two indications that really tied me to the hospital. And then there was a third indication that really tied me to the area, and that was dermatopathology. So
Mhm.
being a dermatopathologist, I mentioned before that I have an outreach business and a clientele of dermatologists all over the state. And dermatologists are very particular. They like 24-hour turnaround time. And, up into this time, for the previous decade before I had digital pathology, I'd actually not left Ithaca on vacation
Oh my
because I
goodness.
was so committed to giving them their 24-hour turnaround time. And, the only way that I could have done that before was being physically present in the place where the slides were. But because it's not a huge part of my business, it's not so burdensome to be able to do an hour or two of sign out of just the derm path cases,
Mhm.
while I'm on vacation. But on vacation before was previously, gardening leave in my own yard. But then I thought, wow, if I had digital pathology and whole slide imaging, I could sign out these cases, from France maybe or from somewhere else. So that was my third use case that really I got me thinking about um, basically geographically untethering me from the region.
I think it's a super powerful something that I don't know is not that highlighted because it's more connected with the pathologist well-being and with the pathologist being able to do their job rather than um, patients, right? It's on the
Mhm.
pathologist side to have a certain quality of life or to have a certain flexibility. And what I'm hearing then, okay, if you didn't have digital pathology, it would, and you would still be on your own. Are you still on your own, or do you have
No, it took me
you have?
14 months though to recruit another
Okay.
pathologist, and that's another factor that was a huge, player into this decision was, the recruitment environment. Now, still, but even especially in 2021 when I was recruiting, was very challenging, very difficult. There's a huge shortage of pathologists, and we're all expected now to do more and to stretch ourselves even further. So we just need the tools to be able to make ourselves even more efficient and to extend ourselves as far as we can to work at the tops of our licenses.
Hmm. Yeah. So without the tools, you would probably have to cut the number of patients. Because I don't know, not be able to serve so much. How many hospitals are you affiliated with?
Two
No,
hospitals, yeah,
two
and
hospitals.
multiple physician offices. And then we
Hmm.
also run the medical examiner program for the county. It's a rural area, so you kind of have to be a jack of all trades in this area. It's one of those things where um, if you didn't have if you couldn't do it, it couldn't get done, or there'd be
Yeah,
delays, or things
it's
would have
not
to
the
get typed out, and
totally. It's not the scenario with, oh, I cannot work with this pathologist, then I'm going to go to another one. There is no other one, right?
yeah.
Yes. So, okay. So you identified a couple of areas where digital pathology would be a game changer. How did you choose the right tools?
Yeah.
When you were looking into tech, how did you pick what to go with? And yeah, did you check a lot of systems or did you have recommendations? How did you go about it?
Yeah. So, I mean, the first thing that you do is you determine your use cases. So, those were my use cases: rapid on site assessment for cytology, frozen sections, and dermatopathology. So, I knew I needed relatively low throughput technology. I didn't need something that was going to be scanning, 200 slides at a time. I was looking for something that had I was looking for whole slide imaging capacity and live view capacity because I figured that the for the rapid on-site adequacy assessment, live view would probably be meet my needs better.
Hmm.
And then I decided on a lot of people go for live view for frozen sections, but I decided to do whole slide imaging for frozen sections as well as for dermatopathology. So I was
Hmm.
looking for a few different types of technology. I was looking budget was a huge constraint for me because, I'm a single solo practitioner. So I set a budget and those were the main two like functional specifications that I had is it had to meet my budget, it had to meet my use cases, and then it also had to be easy to use. Like I needed technology that, like I mentioned before, I'm often called when I'm driving from one hospital to another. If the technology was going to tie me to a computer, it wasn't going to be functional for me. I needed it to work on a tablet, which I can take pretty
Hmm.
much anywhere with me. And so I needed to be able to like pull over to the side of the road and pull something up on a tablet to be able to make decisions rapidly off of that. I wanted to be able to use it easily on the tablet. I didn't want to have to log into another system
And the
and then
five
like pretend
passwords,
like I was using a
VPN, and
mouse. And I wanted to use my finger and
Mhm.
move the image with my finger. I wanted to pinch to make it bigger. I wanted to pinch to make it smaller. So that was pretty critical functionality to me. So I think it's really important to define your functional specifications that you have in order to make sure that the technical specifications meet the functional specifications.
So you say a lot of people go for live view for frozen section, but you decided to go for whole slide imaging. Why did you decide, and did you have any problems with that? What's
Yeah,
the reason why people do live view for that?
there are lots of systems out there for, frozen sections with the trundle that you can manually move from afar. I was priced out of those types of systems.
Hmm.
Um, for the for the live view that I was using for cytology, the cytotech would be moving the slide. And so the
Hmm.
cytotech has, some idea, cytotech knows what they're looking at. And so I could say, oh, hey, stop at that, that group of cells over at 3 o'clock and go in there. And I could be having that conversation with the cytotech. But with the Frasen section, being the only pathologist, I would pretty much be the only one that be knowing what's being looked at. And I would feel less
Hmm.
comfortable telling, a histotech on the other side, oh, hey, stop on that thing that looks kind of square and, move over there. And
Yeah.
um, so that was one reason. And then the price was another. And then the third reason was because, I was getting, this was my first foray into whole slide imaging. And I
Hmm.
wanted to sort of push it to see what could I do with whole slide imaging. I wanted to also have a little more value for the investment that I was making in the whole slide imaging, rather than just for when I occasionally wanted to go on vacation and out of the area and wanted to read those germ path slides. So I wanted to be able to get a little more value for my money. So that was the reason that I decided for whole slide imaging for the frozen section use case.
And the quality is good enough, right?
Quality is excellent. I'm really impressed by the quality of very affordable scanners. And the time that it takes to scan is not prohibitive. It's working out very well even for that intraoperative setting.
So I know a frozen section images only from this. There's a data set TCGA, the Cancer Genome Atlas. They have a bunch of slides, and several of them are frozen sections. In general, frozen sections are not as beautiful as FFPE samples, but they're not going to be more beautiful on glass. It's
Right.
not that a scanner is making those sections more ugly. They just are like this, and you have to work with it.
Right.
So,
You just get what you get.
right, and the scanning doesn't make it any worse. So, okay, going back to the budget, how did you, if it's okay for you,
Yeah.
can you tell us what your budget was for
Yeah.
this whole setup?
Yeah.
And then we're gonna dive into what you bought for this money. But first, what was the budget, and how did you come up that this was a reasonable budget for you that would is not gonna like put you out of business or put you deep into debt?
Right. So I was practicing alone at this point. So I did have a little bit of flexibility because I wasn't paying another pathologist to be doing work. So I basically just set a budget that was $75,000. I thought,
Mhm.
for $75,000, I should be able to get a solution or several solutions that will, meet my needs and meet my use cases. I also didn't want to like dive really, I mean, one, I didn't have more money than that to spend. That was the top of my budget. And then two, I was thought, I'm this is my initial foray into digital pathology. So I mean, it would have been nice if I had a lot more money to spend, but just knowing that that this was my initial foray into it, I thought, okay, well, I think that's a reasonable budget to set to be able to meet my needs, especially since my needs were low throughput. If my
Mhm.
needs were higher throughput, I think that would have been a little more challenging. Or if my needs were to like completely transform my workflow, but they weren't. I just had these special use cases just to get me out of the hospital for very certain things that were absolutely tying me to the hospital.
Okay, so what did you decide to get, and where did you distribute these devices?
Right. So my evaluation process basically was see what's out there. So I did internet searches and
Mhm.
looked in resources like Cap Today and just to see what was out there. I started contacting vendors and just talking to people, asking questions, asking how much their devices cost um, and I was very quickly dissuaded from many products because of my budget to be able to meet all of my use cases. So I um, uh, actually, the vendors were very helpful. Even some of the vendors for the large FDA-approved devices that I was not able to access because of budget, they actually would point me into other directions and say, "Hey, you should call this vendor. They have some really nice products for somebody like you who's looking for something much smaller."
Mm-hmm.
And so that's kind of how it happened. Yeah, I just evaluated lots of different scanners. I found I ended up buying 2 whole slide imagers and 1 live view scanner, and the software platform that I've been using for the whole slide imaging. And so the 2 whole slide imagers I chose it was a Motic 6-slide imager and a Grendium Ocus 20
I
slide
know this
imager.
one.
I liked the fact that I could have 2 of these scanners, so I'd have some redundancy. If one of them went down, I'd be able to use the other. I also just kind of, being informatics boarded and kind of like tech nerd, I just wanted to play with the technology. I thought it was really interesting and really cool. And, the scanners, they were affordable. The Motic, it was under $30,000. The Grendium was under 15. And the live view camera that I ended up getting was from the Smart Media. It was their
Mm-hmm.
product for live view, and one of the reasons that I also ended up going with the live view is because they also had a very nice web application that was available and also in my price range. They had one that's not in my price range, but they also had one that was in my price range for just, scanning, like to be able to store images on a cloud-based platform, to be able to, access them and log in and look at them and move them around on an iPad with your finger and determine what was going on.
Mm-hmm.
So I wasn't able, at this stage of the game to do things like interfacing with our medical record system or lots
Mm-hmm.
more sophisticated things that I hope to someday be able to do with digital pathology. But this was just, this is just getting my feet wet.
Yeah, I like that you say that vendors were helpful, and I'm seeing this a lot more in this digital pathology space. They really want to help, and also they have, especially for people who are new to what's out there, they have already served some people, and they know the use cases. They know why people went with a certain system and didn't go with another one, and they can very quickly point you in the right direction. So, yeah, I like that a lot. Question: where is the Grandium located, the Motic, and where's the live view?
Right. So right now the
Because I'm
Grendium.
looking at your microscope, but there is nothing
No,
on
there's nothing on it. Yeah. So the Grundium is actually going to eventually live here. This is my home office.
it.
I have
Hmm.
a home office and a hospital office. But right now it's still being validated for one of my use cases. And so I'm validating it in the hospital. It's living right next to the Modic scanner. Modic
Hmm.
lives in the hospital. And then
So their bodies right now.
Right. So when wherever the slides are being made so that they can be scanned by technical personnel. And then the idea with the Grendium is that if I'm signing out at home and, my second pathologist is in the hospital and we're in different places, I could quickly scan something to him so he could see
Hmm.
it as well and, weigh in on it. And that way we don't have to do our usual thing of, hey, what do you think of that? you know?
Putting the phone to the microscope
Yeah.
and trying to catch a
The
picture.
the very first digital pathology, right?
Yes, I
So,
remember when the
and
first cameras came out, I
yeah.
was still in vet school. And it was the first time because when we learned histology and then later pathology, we had to draw these pictures and we had a special workbook with circles. Half of the circle was either a picture or already a drawing, and then we had to look under the microscope. And then at some point, somebody had the first digital camera, and we were exactly trying to capture anything from the ocular with the digital camera. That was an interesting exercise. I mean, some people I see on social media, they get decent pictures,
Maybe very
but
good, yeah.
I just don't have the patience or like the dexterity to do
Yeah.
it. I have a specific adapter for this.
Mhm.
I have the Smart in Media as well.
Yeah.
Okay, so another question regarding the equipment. How long have you had it already?
Let's see. It's been almost three years. 3 years.
Oh,
Yeah.
amazing. And how long did it take you to pick everything, validate, like from
Right.
the day where you said, enough, I need digital pathology, to the day where you actually could use it?
Oh, that's a great question. Because there was also a pandemic going on and I was practicing alone. It took me a while. So the day I said I'm going to get digital pathology, that was in September of 2020. And I set myself a deadline to December of 2020 to choose my technology. And I stayed on
Hmm.
track and I chose it and I made my purchases by the end of 2020. I got all of the technology, the following month, so January 2021. And then the easiest thing to validate was, I think the thing I validated most quickly was frozen sections. I think that
Hmm.
that one went easy because I was able to use a lot of archival material.
Oh, yeah, true.
And yeah, and I ended up validating that one first because of my need to kind of get out of the
Hmm.
hospital.
That
Um,
was your most narrow bottleneck, I think.
yeah, yeah, and I was validating concurrently the live view, which is living on our Rose camera in the hospital.
Hmm.
It's on a cart that goes to cytology or
I
goes
need to
to
go to one
pathology.
hospital one time and make a video how they have mobile digital pathology on the microscope driving it.
Yeah. I say it took me about 9 months to get all of the validations just completed with the data and all the scanning and just, reviewing everything. Submitted it all to the state. And I was using it even before I heard back from the state.
Hmm.
But the state, chimed in, I would say 6 or 8 months later
Okay.
about that. So it took about I would say a good year of
Hmm.
validating, but I was a little bit constrained just in my situation, just to be able to get everything
Yeah,
done.
you were on your own.
Also for the
That's a
on-site adequacy.
success.
Yeah, the on-site adequacy took me a little bit longer to validate as well because the way we chose to validate it, since it was a live view, was, in real time, just kind of using it first and then doing our normal process and seeing
Hmm.
how well they compared. So we had to wait till we had enough cases to be able, and that took a few months to be
Hmm.
able to get enough cases to compare them. So but yeah, so we did the validation, submitted it, and it's been great. It's definitely liberating to be able to use the technology. I like using it. I'm getting used to seeing the images. Some images are easier than others to see. I did decide at one point that I didn't want to do huge excisions for subtle melanomas or subtle melanocytic
Hmm.
lesions. I didn't want to use the digital for that,
Okay.
for like multi-slide cases, at least the way that I have
Hmm.
it currently set up, because it's not integrated into the EMR. It's not perfect. But for small biopsies, the basal cells, you know, the um, the frozen sections are fine. Everything looks very, very good on it. We had some trouble validating the special stains, um, because we were having it took us a little while to overcome that hurdle, because the scanner was focusing in the plane of section where the marker was instead of on the tissue.
Oh, okay.
And so we ended up having to erase all of our marker lines on our slides and rescan all of those and try again, and that worked, to be able to do that. So
Marker lines like with the pen?
yeah, like with the Sharpie
Oh,
dividing the area where the controls are versus the tissue.
oh, okay.
Oh,
I understand. See, yeah, those scanners. So you need to be
yeah,
vigilant about these things that like are so obvious for us, but then a device doesn't really distinguish.
right.
Um, so okay, so you've been doing this for 3 years. Let's say you wanted to go one step further, and let's imagine budget is not a constraint. What would you add to your digital pathology arsenal, like to make it even more liberating,
Mhm.
increasing the access to patient care? What
Yeah.
would be the next thing?
Yeah.
And it doesn't have to be, a specific device, but like a use case. Which use case
Yeah.
would you
The
take under the digital pathology umbrella?
the 2 next steps that I think are, most critical to accomplish would be interoperability with the medical record system
Hmm.
and higher throughput scanning.
Hmm.
So I think that I would like to get one of those, larger, fancier scanners that is able to do, all the GI biopsies or whatever. Um, I think high throughput scanning would be very nice. And interoperability with EMRs is absolutely
Hmm.
critical, because I think that if I were integrating this into my daily sign out in a way that enables me to maintain efficiencies and actually read multiple slides in a day, not just a select few.
Hmm.
I would definitely need to. I would want to be able to click on the image and know that the image that I'm clicking on is the one that's with that case. I'd like to open up the report concurrently with it and to be able to dictate into the report. And so that's my dream, and that's actually what I'm working on next, is the interoperability in the EMR. So I'm hoping this will work out. It's challenging when you don't really have a big budget. So
So how are you approaching it? Are you looking for some third party solution? Or are you trying to um do like custom coding? What's your
yeah,
approach to that
it
one?
it's one of those things. So we have an opportunity in that our hospital system is changing EMRs, and so
Hmm.
we're moving to like a more modern medical record system than we've had before. So there's lots of opportunities with that, and with my informatics background, I'm very heavily invested in the EMR. Getting it, making sure that it's very functional and it works well for all the users, and that it's configured properly. And one of the things that I have been looking into with that is digital pathology and the way it integrates into the EMR. The
Hmm.
EMR, it doesn't it at this stage in the game, it's only interoperable with the FDA approved vendors, the big
Oh.
expensive scanners that I don't have access to. So this is one of the kinds where I'm trying to work with Smart Media to
Hmm.
see if we can integrate their product into it, because it was a little more budget friendly for me and for my hospital. So I'm hoping it'll work. It'll be a first. So if it works, it'll be very exciting. But it's new territory.
Oh my goodness, this is amazing. So, okay, this is the ideal world where everything is integrated. How does the day-to-day practice look right now with those parts of your workflow being digital pathology? Most is on the glass. You do it both from the hospital and from home, depending where you're located. And where does the digital pathology? How do you work with images?
Yeah. So for me right now, I basically, since there are two pathologists there, if one of us is in the hospital and there's a frozen section or rapid on-site assessment, or if I'm in the hospital and my derm path cases are there, or a courier can bring them here to my house, then my preferred workflow is glass.
Hmm.
It's definitely it's easier
Hmm.
for me, and the other pathologist, feels pretty much the same way. But for there are times of day that we like to make ourselves more available to the radiology staffing, often on the peripheries of the day when you know, when our normal histology, like when we're done with the glass, we have no reason to be in the hospital other than to be there for, the frozen section or that radiology procedure. And in those instances, we heavily rely upon the on-site adequacy assessment. So what'll happen is, there's an early morning procedure or a late afternoon procedure, and the pathologist is not in house. Um, the cytotech will go up and do the rows, send us a link via the PathoZoom camera. We'll log
Hmm.
in, we look at it just like it's a movie. We watch, like I'll just watch it on my iPad, say, yeah, that looks good. Yeah, that looks hematopoietic, send some for flow, or, oh, there's some, neutrophils in there, let's culture it, or, oh yeah, look, that looks endothelial, let's get a cell block, all the
Uh-huh.
traditional like rows that we're doing,
Hmm.
triage. And so that's been great, and it was a real appealing feature when I was recruiting, for my other
Definitely.
pathologists. I could
Very
say,
much would be
listen,
for me if I was looking for a job.
yeah. When it's getting later in the day and you wanna go home and have dinner with your family, you can do that, because
Pathologists like doing that too.
yeah, we like to do that.
Yeah.
And, it's that waiting for a frozen section isn't gonna stop you because so
Mhm.
I very much enjoy doing that because the ORs don't always run on time, and a lot of the cases that we get frozen sections for, most of our frozen sections are plastic surgery cases. So they're not
Mhm.
as, critical as maybe some other cases. And so if more, pressing cases come in, the plastic surgery ones get pushed. So oftentimes, we might be seeing those later in the day when we're done with all of our routine work and we have no reason to be in the hospital. So
So
it's
do they like text you and say, "Hey, uh, open your computer and scan the
yeah.
code for
Yeah,
the."
they'll say, "Hey," so for the frozen sections, basically the workflow is the technologist who is preparing the frozen section will scan the slide, give me a call or send me a text and say, "Hey, we just started scanning the slide. It should be uploaded in a couple minutes." And then I log in to on the iPad, no matter where I am. It's very easy to always have the tablet with you, and so I could be out to dinner, I could be in the dentist office, it doesn't matter. And I can take care of that frozen section, as soon as it uploads, call the surgeon, let him know what I'm seeing. Yeah, and then it's just done.
Perfect. What I did recently? I just got the smart in media camera, and I had a lecture for non-pathology students about pathology data. And I did a demo for them and let them guess what slides I had on the stage. And I just had them scan the QR code. And of course, the first thing that they started to do is draw on it and annotate and like draw circles and hearts. I'm like, that's at least interactive. Good teaching tool as well. So that was fun. Beth, you are working with community hospitals.
Mhm.
Um, how did they react to this new cutting edge tech? And like, what was their reaction to you proposing this um, going digital? Or maybe did you do it together? How was that when you
Yeah, I have a
suggested?
yeah, I have a very supportive hospital environment. So administration gets it. Especially, I think COVID really got us to a point where we were understanding, utilizing technology to extend us and to be able to. We were used to doing Zoom meetings where we're sitting in our homes and babies walk into the room and climb up in people's laps, and dogs come across the Zoom camera and cats are walking all over. And, we got used to that. We got used to doing, our tumor boards now are all Zoom. Um, and so the idea of using technology to be able to extend the resource, they saw what working alone was doing to me. They saw,
Yeah.
they saw how hard it was. They saw how hard the recruitment environment was. They saw how difficult it was to recruit for other specialties as well. So, I mean, I think that administration gets it as a tool, and they're also very supportive in trying to help me with my crazy scheme of trying to become interoperable with the medical record system. So I think it's very helpful to have a supportive hospital environment. They didn't have extra money to throw at it, but they were basically they knew that this technology would help me extend the resource so that I could provide more services. I
Hmm.
could I could say, okay, listen, we can have frozen section hours, that are longer because I'm available.
Hmm. Hmm.
I'm more available. Like I can't be available if I have to go to this hospital, and we don't want to limit procedures. I never want to be the rate limiting factor in a procedure. And so I think that, showing them this allows me to not be the rate limiting factor is good for hospital, throughput and bottom line and patient care and all of these things too. So the hospital reacted pretty well. I think it's sometimes a little challenging with the frozen sections because it does extend the turnaround time a little bit for me since I am using whole slide imaging. So they're not, they're used to being able to have the
Slide is
slide
ready.
on the glass,
The
have the
Mhm.
instant answer. Now there's a slight delay of the few minutes that it takes to upload the image. And I think sometimes the surgeons who
I don't think they
didn't grow
belong
up
to
with
the
this
most
technology.
patient group of professionals either.
Yeah, they're pacing back and forth, and so I think that there's, but I feel like once people get used to it, and once surgeons are coming in that have seen this in use for their entire careers, or have seen me using this for their my entire career, or my entire career that they've been with me, then they'll
Hmm.
just see it as normal, and so I think
Yeah.
that over time it becomes, people get used to it. So the
But
technologists like it. The technologists
yeah,
in the laboratory love having tech that that it's even though it's more work for them to scan stuff, they see what it does. They see that it extends the reach, and that it makes things easier, and allows for other use cases as well. We're using it now for tumor boards.
mm,
We've been looking at how can we use this to save money with our send out costs. Can we scan the images to the hospitals where the patients are going for second opinion, rather than FedExing slides with tracking
yes.
numbers and things like that. So I think that they see that there's possibilities with it, and
I
and
was
also
not
technologists love technology, right? So,
right. They're technologists, but
right.
I was not. See, I recently only learned about this requirement, and then when somebody's going somewhere for second opinion, the slide and the specimen the diagnosis was made of has to go with them because
Mhm.
their pathologist has to confirm.
Right.
And I learned it in the context of yeah, of doing this digitally instead of sending glass, because sometimes it would take longer to ship the glass there than to bring the patient.
Yeah, yeah. And it's very expensive because, you have to make sure that there's tracking numbers on these specimens, that they are good, that they go quickly. Sometimes, we're sending them overnight, and that can get very, very expensive, especially if you're sending to multiple different hospitals every day. Which
Yeah,
we
true.
do because patients go, all over.
Hmm.
So I think that there's definitely, it's it could maybe even help offset some of the costs of purchasing the technology, if you can, use these as justifications, as this is going to ultimately help us in the long run. And I think the real justification is the pathologist resource, because we are the most scarce. There,
Yeah.
it's a very challenging recruitment environment. um, it's now that people are kind of used to having a little more flexibility with work, there's people are demanding it. And so if we can help provide that, then if there's
Yeah. And
technology that can support us in that, then we should definitely be exploring it. And I hope we get there. I mean, the radiologists in our hospital are
they
100%
do that,
remote.
right? And
Yeah,
they're
they've
the
been
same
using.
rural area that you are.
Yeah.
Like, what's the deal?
Yeah.
Pathologists can have that too.
Yeah, and I feel like radiologists are pretty far ahead of pathologists in the digital landscape.
Yes.
I feel like they've been digitizing things for much, much longer. And so I don't know, maybe in 20 years we'll be at like the radiology level of normalization of this technology and adoption
Hmm.
into our daily lives. But it's exciting to be on the leading edge of it, and to be adopting it in early and innovative ways, and trying to mold it to meet my needs and meet my practice. It's very satisfying to accomplish it when it works. So.
Your practice owns all the tech,
Mhm.
and you basically have it where it needs to be used.
Correct.
Okay,
Yeah, and
understood.
I needed to do it that way because one of how rapid my timeline was, and how quickly I
Hmm.
wanted to move. I wasn't going to be able to wait for capital cycles and apply for things, and also the hospital environment, they have so many priorities that are competing. This was my, number one competing priority. So I knew that if I wanted to make this happen, it was going to have to be my practice that ponied up the capital for it. So that was my reasoning for it. And but yeah, it's been working out. The technologists are the ones who are truly, doing all of the scanning, using
Hmm.
using it in the day to day, and I'm just sort of the end user beneficiary of it.
I think it's extremely empowering that you could, like you say, okay, that was my priority and I did it. I chose what I needed to choose and I brought it to them. They said yes, and we can now do it. because you're also in the position that you're working with multiple institutions. So you're the driving force. But I think this story is basically empowering others in your position and others who work independently. Hey, we can be the drivers of this. We don't have to just like say yes if somebody offers this to us. We can consider on our own if it's gonna bring more business into the practice, if it's gonna increase the access to care, if it's gonna increase the flexibility of our life. And if the answer is yes, hey, let's budget and let's do it like you did. I
Absolutely.
think this is so cool. I
Absolutely.
think it's super cool. So
Yeah.
if someone else was in a similar spot and was thinking about getting into digital pathology, what's your advice? Or like, what are the traps that they should avoid? Or
Yeah.
I don't know, something that maybe you would do differently right now.
So I think compliance reasons scare a lot of people. I think people are very
Mhm.
frightened of technology that's not FDA approved. I think people find that that's a barrier, and it shouldn't be. People should be able to access the non FDA approved technology. You're going to have to do the same validation anyway when you're internally
True.
validating it. And the College of American Pathologists gives you really good resources. I mean, they basically tell you, step by step what you need to do in order to produce a validation that's considered acceptable, which is, it's just like any other laboratory test, right? So if you just approach it like any other laboratory test and I think that just knowing that there are options out there that aren't FDA approved, and that the validation, the internal validation that you're going to have to do is going to be exactly the same, whether it's FDA approved or not FDA approved. So really, like if you think the technology is good, then it's good enough, right? Because you are
If
the
you, as a
standard,
board certified pathologist,
right?
decide that you can do diagnosis on this
Yeah,
and, compare it to whatever CAP says, I think it's 60 cases that
yeah.
you have. Yeah, anyway, then that's what it is, right?
Yeah, yeah. So I think that's a huge thing because I remember, very early on, when I would tell people about this, they'd be like, but you're going to get in trouble with the regulating bodies and blah, blah, blah. And I'm just like, I don't think so. Like it's like they give you paths to do laboratory approved tests in the state. Like I followed it and the state said okay. And so I think it's definitely I think people consider that a barrier. And it's probably just because, not a lot of people are doing it, the way I did it. And it's just sort of an
Hmm.
individual who is just needs it, like needs it to function.
Yeah.
Um, and so I think just sort of if you have that need, like one, overcome that barrier. And then I think that the other barriers that people tend to have would be definitely the financial barrier and also the barrier of making sure that your hospital administration or whatever the administration that you're working with is on board and can provide technical resources and is supportive of the technology and agrees that it meets HIPAA compliance and that data privacy standards and all of these things that are out there. Making sure that you have a supportive environment from that perspective to be able to meet those barriers, I think is also pretty critical. There was at one point our uh, uh, my access to the data platform where the images were stored was blocked because this was right when Russia invaded Ukraine. And the hospital decided to block all European, uh, you know,
Wow.
web web
Smart in
sites
Media is from
working.
Germany. Like, okay.
Yeah. So Smarter Media was blocked, and it took me. It was one of those things that took me a couple days to work through with
Hmm.
my IT staff. Like, no, this is they're
This is safe.
they're
I
not going to
need it
start World
to do
War
my
III.
job.
Like it's Germany. It's okay. Like
Oh my goodness.
but yeah, so things like that. And just evaluating things and keeping it moving forward and just I would say I'm very satisfied with the technology I purchased. It works very well for me. It meets my needs. And it definitely gives me um, sort of a foothold into the field that makes me ask more questions and makes me think of what we're going to need the next level to do and what the next level to meet. And it's just I'm approaching it very iteratively, and I think that that's another thing too, is I would recommend for people approaching it iteratively. I can't imagine trying to dive in and completely redesign my workflow. I think that's another thing people get scared of. They're like, "Oh gosh,
Yeah.
like I love my microscope. I love glass, like I don't want to move away from that." But if you don't like most of my work is glass. The digital stuff is just the icing on the cake.
Mhm.
And I can see
And
an
that's
environment.
okay, right?
Yeah.
Because, you know, maybe not now, not so much anymore, but a couple of years back, it was like hospital going digital, all full like no glass anymore, everybody on the screen. And people who like don't have the luxury of having an institution or like having a dedicated group coordinate that and coordinate the phasing out and then just going to digital think it's not accessible to them. And
Mhm.
that's not. You just use it iteratively and in a different way. So Beth, if you decided, okay, I want to grow my practice, would digital pathology be a tool that would help you grow it, like have another person or
Oh, absolutely.
yeah?
And in fact, like our hospital system is looking at affiliating with another hospital system. And that
Mm-hmm.
other hospital system has had an extremely difficult time staffing their anatomic pathology lab. They have a hard time staffing pathologists. Same thing, recruitment environment.
Mm-hmm.
It's also
Mm-hmm.
a very hard environment to recruit technologists, histotechnologists, cytotechnologists. It's very hard to get all of these things in place. So I can see a future where we are, consolidating resources for anatomic pathology for multiple institutions in a centralized environment, and using the digital pathology not only to share cases amongst pathologists, but to be able to do the frozen sections, the on-site adequacy assessment, even just daily sign out. I think if we can get to a point where we've got high
You can
throughput
scan the
scanning and
slides.
good interoperability with the EMR, I can see a future, especially if we're expanding and growing, and that will help normalize the workload. It will help people be, working at the tops of their licenses and be more efficient, to be able to work from anywhere. And it'll be attractive to recruit pathologists if we can tell them they can work at home if they want to work at home. And I think that that's, giving people that sort of flexibility. I think would be the next steps is the higher throughput, the interoperability with the EMR, and moving even more toward incorporating it into daily routines and sharing across geographic distances. I mean, when you're in a rural environment, it's you've got a lot of space
Yeah.
between
Yeah,
hospitals.
that is true. That is true. And not everybody wants to come and work in a rural area. And this is amazing. I love your story. I love very much how empowering and how like you just did it. And that always gives um the sets a super cool example and shows that it can be done. You don't have to wait for anybody. If you need it, just do it. There is a way to do it without like going out of business. And you can serve more patients, and that there are budget friendly tools that can um, unblock the bottleneck.
Mhm.
Yes. Thank you so much for joining me, and thank you so much for telling my digital pathology trailblazers about how you did it. You are a true pathology
Oh,
trailblazer.
thanks, Alex. I appreciate the opportunity. I love the technology. I love sharing it. The more of us that are out there doing it, the better it will get.
Yeah, and then, those who come after, that's gonna be what they see. That's gonna be what they're used to, and uh, there's not gonna be so much fear. There's not gonna be so much misunderstandings because that's gonna be what they step into when they start
Yeah.
practicing.
Yeah, and the
Yeah.
barriers will go down. The hospitals will want to adopt it because
Mhm.
everybody else is doing it. So,
Yeah.
no.
Thank you so much, and you have a wonderful day.
Thank you. You too.
Thank you so much for staying till the end. I felt this episode was really heartwarming when a person, a pathologist, a female pathologist from a one-person practice can uh, can go digital and can help more patients than she would without those tools. And if you want to check two of the tools that Beth was mentioning, the Grandium microscope and the Smart in Media Live View camera, I will have them linked on the screen here or here. You can check out in more details how those tools work. And I talk to you in the next episode.